Good morning, good afternoon, good evening, wherever you are in the world. It's a pleasure to be here today. Welcome and thank you for joining us today in our amazing, exciting program. I'm so excited to be here with you today. But we are going to be talking about living with rare liver disease in Europe. We have a number of speakers today, for which we are eternally grateful. We have a number of endorsees today. So we are firstly endorsed by EASL, which we'll talk about very shortly. We're endorsed by the European Reference Network for the Hereditary Metabolic Disorders. We're also endorsed by Liver Patients International, again, about which we'll hear more later. And we are also endorsed by the PBC Foundation. So we thank our endorsees for supporting this event, and we are very proud and pleased to welcome you. So on the subject of welcomes, we are going to introduce our first speaker. I will say this morning, in case anyone is on the other side of the Atlantic and has joined us, I'll say good afternoon to anyone who is here in Europe, and I'll say good evening to those of you who are further afield in Asia or Australasia. So, our first speaker, I would be absolutely delighted and proud to welcome a hepatologist, a professor of medicine at Hospital Universitaria Valley-Hebron, and of course the EASL EU Chair of Policy and Public Health. Professor Maria Buti, good afternoon to you and welcome.
Thank you. Thank you very much for your kind presentation. Good morning, good afternoon, good evening to everybody. Many thanks for inviting me to this event devoted to rare liver diseases organized by the Global Liver Institute. I am today representing EASL as a chair of policy and public health. It is really an honor to be here in this meeting during the month of rare liver disease and support the hashtag Rare Aware campaign to raise awareness, enhance education on rare liver diseases, and advocate for a greater political response to improve patients' lives. These patients struggle to get a correct diagnosis and the treatment and the care they urgently need. As you know, it is estimated that 30 million people in Europe are living with a rare disease, and around 400,000 of them live with a rare autoimmune liver disease. And what is really important is half of these rare liver disease can start in childhood. Collectively, rare is many, and rare diseases are a significant public health burden. Despite their rarity, the liver diseases account for a disproportionate number of patients in the liver transplant program, reflecting the significant unmet needs with regard to effective medical treatments. For example, in the European Transplant Register, rare liver disease cumulatively account for 22% of liver transplants in 2017. Another example is primary sclerosis cholangitis. That is one of the indications for liver transplantation, has no medical treatment, like 95% of other rare liver disease. And for the remaining 5% of this rare liver disease, there is inequity of access to treatment between different countries. So really, these are important issues to solve. At EASL, we are boosting partnerships with umbrella patients organizations engaged in liver disease, including rare ones throughout our patient synergy activity. And Global Liver Institute is one of these organizations that we collaborate. Additionally, EASL is closely engaged with the European Reference Network on Rare Liver Disease. This is an European-wide network for centers of excellence in the clinical management of rare liver disease in adults and in children. In the hospital that I am working it's also collaborated in this European reference network. Together, we aim to help improve care and to advance our rare liver disease awareness, research, and education. For this reason, EASL is running webinars, and also last year, School of Medicine enabled adult and pediatric hepatologists to learn the latest on managing this type of disease. This year, on June 22 to 26, EASL will hold its annual International Liver Congress, known as ILC. It will be in London, and we're planning in this ILC meeting different sessions for rare liver disease, such as interactive sessions, a mid-expert session. There will be also in the postgraduate course an update on diagnosis and treatment of Wilson disease, and we're planning a med-expert session on alpha-1 antitrypsin deficiency. In addition, we have a dedicated abstract category on rare liver disease, and this includes pediatric and genetic diseases. And I am also very happy to announce that next week, the EASL studio, that it's a new activity, it's like a TV that is running every Wednesday, is hosting a special episode on rare disease with focus will be focused on progressive familial intrahepatic cholestasis. So we are going to discuss with experts the new therapeutic options, the clinical presentation, and also clinical trials on this rare liver disease. EASL also offers some learning resources on rare liver disease that are available at EASL campus. This is a multidisciplinary electronic learning hub. And in this platform, we have open access to a wide variety of interactive resources, also some tools for the last ILC, a webcast, slide decks, and so on. And finally, I would like to remark an special report done last year, that is the EASL Lancet Commission on liver disease. This EASL Lancet Commission on liver disease was published, the report in the Lancet in December last year, and the title is Protecting the Next Generation of Europeans Against Liver Disease Complications and Premature Mortality, because we realize that here in Europe, liver disease are the second cause of lost years of working of the population. And in this big report, there is a special section devoted to the complex and costly care of rare liver disease. I think this is really important to have a specific session for rare liver disease. And in this session, we highlight that early diagnosis and cost-saving therapies can be achieved by establishing screening, standardized treatment protocols, and centralization of patients with rare liver disease in these specific liver units, particularly in pediatric liver units. So thank you very much, Robert, for inviting me, and also on behalf of EASL, and I hope all of us are going to enjoy this meeting.
Wonderful, Professor Booty. Thank you very much for your words. So I would like to ask you just a little, because we obviously here at GLI, we're operating Rare Liver Disease Month. As we work towards next week with February 28th being Rare Disease Day itself. And the fact that you're operating EASL Studio next Wednesday, which I think is a wonderful innovation, and thank you very much for bringing that to us. The question, particularly for patient advocates who might be watching at the moment, how can they get involved? Do they need to be EASL members to watch EASL Studio next week, or can they join at a link?
No, you don't need to be EASL members, so you can join, and even this type of activities remains at EASL webpage. I can tell you that this session will be early on Wednesday at 6 p.m. Central European time, and as you know, and one thing that EASL is doing, and particularly we are increasing from the time I am sharing the policy and public health, is relation with patients' organizations. We think that relation with patients' organization is extremely important. And the role of, we cannot go directly to the patients, but we can contact with patients' organizations. And I think this is extremely important. And patients' organizations has to be part not only of our activities, also have to be part when we plan these activities.
Absolutely, thank you. And it's reassuring to hear those words, and thank you for your efforts. And yes, I may be a tiny little bit biased in the sense that I'm absolutely convinced that the more that patient advocates are involved, in example, at the ILC, the International Liver Congress, I think it helps the community in general. So one last question, if I may. And before I ask this question, just a reminder, if you're watching today, please feel free to put your questions in the comments box and we'll do our very best to address those. But my last question for you, Professor Booty, this afternoon. How best can patient advocates engage with the ILC, and what can they do when they get there in terms of not only learning from EASL and taking that back to their patient populations, but actually engaging directly with EASL and helping EASL in its own journey?
I think we have, in addition to ILC, we have after ILC, we run another activity with patients' organizations. We have done this the last 2 years. And I think this is a very, very important activity. It's about 2 hours. It's a webinar, and it's a conversation. So I think the attendance of this event it's also very important, and we select a topic and discuss from different points of view. So for me, this is really a good activity related with ILC, that we move from a physical attendance, because it was very, very limited, to a webinar that is open, and I think it's open for everybody.
Okay, fantastic. So thank you. So I guess the message is that patient engagement is not just for ILC, but it is forever. So that's a great message, and we'll take that away. So thank you very much. Professor Booty, we appreciate you. We understand how busy you are, and we're absolutely delighted that you could be involved today. And thank you very much for being here.
I will stay for a while. I am not sure if I can be until the end, but I will like to learn.
Wonderful. That's very kind. Thank you. And if we have any questions, come in the comments box. We will direct those to you as well. Okay. Thank you very much to Professor Booty. So as you know, we are having a number of presentations today, which we're absolutely delighted to share with you. Now, do bear in mind that we have banners that will be flashing through the screen with lots of information. And if we get the opportunity, we'll share with you some of the information about EASL Studio, which is happening next Wednesday as well. So what I would like to do is I would like to now introduce a professor who's the head of unit at the Metabolic Disease in Bambino Gesù in the Pediatric Hospital, Italy. So if you will please, I would like to invite Professor Carlo Dionisi to talk about major rare metabolic liver disease in children. Thank you.
Colleagues, it's a great pleasure to be here to present this short lecture on major rare metabolic liver disease in children. I'm Carlo Dionisivici, I'm metabolic pediatrician in Rome, and I'm leading the metabolic disease unit at the Bambino Gesù Children's Hospital. Since most of people are not so familiar with the inborn error of metabolism, I took the most simple definition from Wikipedia. Inborn error of metabolism for a large class of genetic diseases involving congenital disorders of enzyme activities. The majority are due to defects of single genes that code for enzymes that facilitate the conversion of various substrates into the products. And this is an example of what is a scheme of what is a metabolic disease. Metabolic diseases can be classified according to the organelle, subcellular organelle, where the metabolic process is involved, or can be classified according to the metabolic pathways that are affected by the genetic defect. As you have seen, the metabolic diseases are genetic disorders, and they are inherited as autosomal recessive or X-linked traits, but also through the mitochondrial DNA, and very rarely as autosomal dominant diseases. Different from many other genetic diseases, metabolic diseases have peculiar biomarkers that allows the diagnosis. So through an analysis of plasma or urine, we can diagnose a metabolic disease. Clinically, since the metabolism happens in any organ and system, metabolic diseases are very frequently manifest as systemic disorders, but all organs and systems can be affected. And today we are talking about the liver. But how many metabolic diseases exist? This is the last classification of inherited metabolic disorders that was made at the end of the 2020. And this classification listed over 1,400 diseases divided into 24 categories and in 124 groups. So it means that metabolic diseases are rare diseases, but very complex in their area with over 1,400 disorders. But why the liver is so important? Because if we move to the history, the Etruscan liver of Piacenza, where there is a design of the liver structure, and we move to the most advanced knowledge that we have today, we can see that many metabolic processes are driven by the liver, and these processes are very important for our body. In particular, the synthesis of lipids, beta oxidation, lipogenesis and ketogenesis, all glucose metabolism, from gluconeogenesis to glycolysis to glycogen synthesis, happens into the liver. And finally, another very important cycle is the ureagenesis, and this is an example. You see that the ureagenesis is composed of 6 enzymes and 1 carrier, and all these steps represent a metabolic disorder that is related to a liver disease. Very recently, Carlos Ferreira from the NIH and other colleagues published a paper presenting the metabolic disorders affecting the liver, and moving from the whole classification from the 1,400 disease, we see that 1/10 of these diseases affect the liver, and they can be divided in 9 major categories: the disorders of nitrogen-containing compounds, the disorder of vitamins, cofactors, and metals, the disorder of carbohydrates, the mitochondrial of energy metabolism related to mitochondrial organelles, disorders of lipids, the storage diseases, peroxisomal diseases, and the category of congenital disorder of glycosylation. Clinically, the most common scenarios in pediatrics are infantile cholestasis, acute liver failure, hepato with splenomegaly, hepatosplenomegaly, sometimes cytolysis with elevated transaminases, but also structural liver changes like steatosis, fibrosis, cirrhosis, or even cancer. And the red flags suggesting that the liver disease might be caused by an inborn error of metabolism are the following: a suggestive family history, the recurrent presentation during episodes of catabolism like fever, like gastroenteritis, they can lead to a metabolic decompensation, a chronic or recurrent vomiting, failure to thrive, the presence of dysmorphic features, a selective food aversion like in fructose intolerance, the presence of an unusual fluid odor, or the evidence of systemic involvement. In relation to this last red flag, the combination of systemic signs are very common in metabolic liver disease. And I will present you some examples related to the age of presentation. These are some examples of infantile cholestasis in which the diagnosis can be made at a glance. This is on the left side, you can see an infant presenting at birth with cholestasis, with hypoglycemia, lactic acidosis, and with a peculiar eye movement that is called opsoclonus. And this is related to a mitochondrial DNA depletion caused by mutation in this gene that is called TGOK. Another example is the Beggar Syndrome, the classical peroxisomal disease, in which the predominant symptoms are the massive hypotonia, of course, the liver involvement, but also some specific facial features and the wide anterior fontanelle. Another example is the arthrogryposis, renal Fanconi syndrome, cholestasis. This is a so-called ARC syndrome that is also accompanied by skin signs, in particular the ichthyosis. And finally, this is a child presenting with a massive hepatosplenomegaly at birth with an ascites, but presenting another peculiar eye sign, the cherry red spot. And this is the classical features of Niemann-Pick disease type A due to acid sphingomyelinase deficiency. If we move to childhood and adolescence, we see here a patient with a glycogen storage disease type 1A that is characterized by hepatomegaly, by the increased liver icogenicity, by hypoglycemia, fasting hypoglycemia, and this disease is absolutely treatable by diet. And you can see here how is improved the metabolic profile of glucose levels by introducing a specific diet for glycogen storage disease type 1A. Two other examples are storage diseases like Gaucher disease or acid sphingomyelinase deficiency, in which there is not only hepatomegaly, but you can see here how massive is the splenomegaly that combines with hepatomegaly. And this is a patient with a Gaucher disease. This is a patient with acid sphingomyelinase deficiency, the so-called Niemann-Pick disease type B. And you see that both conditions are now treatable by an enzyme replacement therapy. And the final example is a patient with a mucopolysaccharidosis type 1A, in which, together with visceral signs, in particular, you see the massive abdominal distension with hepatomegaly and sometimes splenomegaly, but this combines with abnormal facial features, with skeletal abnormalities, and also with eye signs. And this disease is also treatable by hematopoietic stem cell transplantation or by enzyme replacement therapy. Very recently, the Italian Society for Pediatric Gastroenterology and Nutrition published two important papers. The first is the diagnostic approach to neonatal infantile cholestasis. And as you can see here, there is a long list of metabolic diseases that can cause infantile cholestasis. The second paper is a diagnostic approach to acute liver failure in children. That's a very important situation, because most of these patients with acute liver failure, they are candidates to liver transplantation. And you see that the inborn error of metabolism should always be considered in the differential diagnosis of infants and children with acute liver failure. And there was a strongly agreement between all members of this liver disease working group within the society, Italian Society for Pediatric Gastroenterology and Nutrition and Hepatology. But how we can diagnose an inborn error of metabolism? We have seen some clinical example. We have mentioned that metabolic diseases have biomarkers. And I think the new frontier for the diagnosis of inborn error of metabolism is the expanded newborn screening. And Italy is one of the most large panels of diseases that are included in the newborn screening program. You can see here on the left the traditional screening for hypothyroidism and also the traditional screening with cystic fibrosis. But now, with the advent of tandem mass spectrometry, we can screen the acyl carnitine and the amino acid in a single run. And this allows us to open a window on the intermediary metabolism. And as you can see here, we can detect beta oxidation defects, amino acid disorders, in particular the organic acidemia and urea cycle diseases, but also the galactose disorders. So it means that within all these yellow square, there is the possibility of having metabolic liver diseases. And these diseases are treatable and can be detected at birth. So it means that the early initiation of treatment will represent an improvement of the prognosis. And the more clear example is hereditary tyrosinemia type 1, a disorder in which the risk of developing hepatocellular carcinoma was quite constant before the advent, at the end of the 90s, of the therapy with nitisinone due to the invention, to the idea developed by the group in Gothenburg. In 2021, you can see that this paper showed the long-term effect of nitisinone therapy in tyrosinemia type 1. You see that there were over 300 patients enrolled in the study, and the major conclusion is that neonatal screening was the most effective way of ensuring early treatment, and the occurrence of liver transplantation or death due to hepatocellular carcinoma was more frequent the later that treatment was initiated. So it means that newborn screening allows to prevent the development of hepatocellular carcinoma in tyrosinemia type 1. But I want to conclude this lecture talking about liver transplantation in metabolic disease, because there is an evolving trend in liver transplantation for metabolic disease. And this is clearly written in this paper that was published in 2019. The indication for liver transplantation in metabolic diseases are evolving, and liver transplantation is increasingly used for phenotypic correction. Children experience a 6-fold increase in liver transplantation for metabolic diseases without structural liver abnormalities. And to prevent metabolic crisis and neurological damage, transplantation should not be delayed. And this is an example of the categories of metabolic disease when considering liver transplantation. We have 4 categories: disorders with liver structural abnormalities and disorders without liver structural abnormalities. Disorder in which the metabolic disease is confined to the liver, and disorder in which there is a systemic or extrahepatic expression of the disease. And back to this group of disorders, the so-called intoxication type metabolic disease, there is an example of the trend in the number of transplantation in the States. You see urea cycle disorders, organic acidurias, and maple syrup urine disease. You see moving from 1987 to 2017, you see how are increased the number of patients undergoing liver transplantation with these diseases. And this is our experience at the Bambino Gesù Children's Hospital in Rome. We performed in the last 10 years 66 liver transplantation for metabolic patients. And you see here, there were organic acidurias, urea cycle defects, MSUD, all representing the so-called intoxication type metabolic disease. And I want to tell you something about the outcome of these patients. You see that the indication in these patients were early indication: poor metabolic control, frequent hospitalization, risk of neurological disorder, risk of death, dietary restriction, and poor quality of life. The long-term complication in which there was an indication for liver transplantation were cardiomyopathy, chronic renal failure, the possibility of having optic neuropathy, and chronic pancreatitis. So liver transplantation may cure these symptoms. And this is our experience, to see that this is the age of transplantation. The median age is, in all cases, below the age of 5 years, the median age. And what is the impact of transplantation? You see that these patients were on protein-restricted diet before transplantation. You see that there was the patient withdraw the protein restriction with an improvement, of course, in the natural protein intake. We observed an improvement in the cognition. So in these disorders that are at risk of having neurological damage, there was an improvement in the IQ or in the DQ. And importantly, there was a clear and significant improvement in the quality of life of this patient, with a patient survival that is about 100%, a graft survival of 100%, the absence of metabolic crisis after the transplantation. So my final message to the Global Liver Institute is that we need to increase the awareness of the existence of rare metabolic diseases in children, because most of these diseases are treatable, and it is really very important to continue in the diffusion of the knowledge in these diseases. Thank you very much for your attention.
Wonderful. Professor Dionisi, thank you so much for that presentation. That was very thorough and very comprehensive indeed. Now we're looking at the comments, and so far the comments have been congratulatory, which is a great thing, but questions are welcome. So do please feel free to ask your questions, and they would be most welcome. Now what we'll do is we will bring our panel together, and we will treat any questions that come in as an opening point for a healthy discussion. Now we have clinical experts and patient experts in the room, and we always know that will produce an interesting conversation. So we're very much looking forward to that. But do please keep your questions coming in. Okay, so from Professor Dionisi, we're now going to move to Austria. Now, I know it's often said that men grow up to be boys, but what we're going to do is we're going to follow the normal timeline, in that children, all going well, grow up to be adults. So we're now going to look at challenges in adult rare liver diseases. So for that, as I say, we go to Austria. We're going to welcome a gastroenterologist, hepatologist, specialist in internal medicine from the MedUni Vienna in Austria. So over to you, please, Dr. Thomas Reiberger. Thank you. So just while you're getting set up, there we are. I see you. So we will get started now, and over to you.
Hello, colleagues. Thank you for inviting me to speak about challenges in patients with rare liver disease in Europe. Especially, I want to send you greetings from the Vienna Hospital and give you our perspectives on some rare liver diseases. You will see that there are many rare liver diseases, but particular expertise that I want to share with patients with autoimmune liver diseases, autoimmune hepatitis, PBC and PSC, patients with vascular liver disease, most prominently Budd-Chiari syndrome and portosinusoidal vascular disorder, and genetic liver diseases such as Wilson disease, alpha-1 antitrypsin deficiency, and cystic fibrosis-associated liver disease, and finally also rare malignancies such as the intrahepatic cholangiocellular carcinoma. So for the adult rare liver diseases, I want to start with outlining some European epidemiology. So in terms of liver disease in general, it needs to be highlighted that cirrhosis causes 170,000 deaths per year. And liver cancer is also responsible for 47,000 deaths per year. And we perform 5,500 transplants a year in the European Union. The highest mortality is related to alcohol-related liver disease, and the prevalence of hepatitis B and C is still quite high in European countries. And fatty liver disease, NASH or metabolic associated fatty liver disease is on the rise, with some countries reporting up to 44% prevalence. And in patients with diabetes, this might even go up to 70%. In contrast, patients with rare liver diseases, as by meaning, with the example of autoimmune hepatitis, the prevalence is between 10.7 and 16.9 per 100,000 inhabitants, as reported from these studies conducted in Norway, Spain, and Sweden. Importantly, when you compare the incidences and the prevalence rates to Asia and to America, you would
Okay, we have a break in connection. I often say this, to err is human, but to completely foul it up, you need to involve technology. So we're going to go and try and connect again with Dr. Reiberger in Austria and see if we can bring him back and his presentation. So in the meantime, I'd like to talk a little about some of the things that we are doing in Rare Liver Disease Month. So if you are involved in patient advocacy, if you're involved in any way, we would love for you to be involved with Rare Aware. So this is the campaign that we're running this month, and what we're asking you to do is use our toolkit. So what we have is a number of opportunities for you to get involved and to use the tools that are available on the GLI website. So what we'll do is we'll share the banner with you where you can see where our toolkit is, and you will have the opportunity to not only show that you are Rare Aware, but also that the fact that you can make other people Rare Aware. So what we'll do is we'll get the banner up on the screen very shortly. Now, as per live TV, I'm hearing that we've still not reconnected with Dr. Reiberger yet. So we're actually going to move on and invite our next speaker to present to you. And then what we can do is try and reconnect with Dr. Reiberger as soon as possible. So at this moment in time, I will come to Dr. Tortora, who is going to talk about the major rare liver diseases in adults. So she's going to cover Wilson's disease, polycystic liver disease. Dr. Tortora is a gastroenterologist, internal medicine, and rare liver diseases in Gemelli University Hospital in Italy. So we will invite then Dr. Tortora to make her presentation, and then we'll see if we can fix something with Dr. Reiberger as soon as possible.
And thank you for this invitation. Today we discuss together about a very rare disease, the Wilson disease. It is a rare autosomal recessive disorder of hepatocellular copper. It involves gene ATP7B and its protein synthesis. The prevalence of Wilson disease, if quoted, has in 1 in 30,000, but recently estimates from sequencing studies have been much higher. The genetic prevalence could be higher than the clinical prevalence because of incomplete penetrance of the disease or for the presence of other genes that we have to be individualized. Therefore, it is likely that interacting epigenetic and metabolic factors are contributing to the varying phenotyping of the Wilson disease. The chromosomes involved in the Wilson disease are the 30. As we know, the Wilson disease is a rare autosomal recessive inherited disorder, and this means that for clinical manifestation, the patient have 2 genes modified. All patients receive a copy of gene from mom and a copy from dad. Then, if we have 2 normal gene, there will be an unaffected child. If we have only 1 copy normal and 1 modified of gene, we have an affected carrier child. Then, if we have 2 gene modified, we have an affected child. The gene causing Wilson disease is the ATP7B that encodes for ATP7B protein. The function of this protein is to regulate cytoplasmic copper in hepatocytes, pumping it out of cells in the bile duct or into endomembrane system. To date, over 600 mutations in ATP7B have been identified, caused by numerous regions, and all of regions can present a mutation. The mutation of the gene present a different distribution in the world, and for this the prevalence of this mutation is different in different regions in the world. We know that the variant H1069Q is more prevalent in Europe and North America, and the variant R778R is more prevalent in Asia. The copper is very, very important. It have a beneficial role in the body because it's an important component of various vital enzymes. The metabolism of copper is very complex. The copper is taken up from the diet in the enterocyte and subsequently fluxed to the liver through the portal vein. From the liver, copper is distributed to the general circulation to provide the tissue with the required copper. The excretion of copper from the body is mediated by biliary export, and the distribution of the intracellular copper is facilitated by a group of protein called copper chaperone. Very, very important for the circulation of copper in intracellular are the ATPase protein. In the bowel, an important role are ruled by the metallothionein that can regulate the absorption of the copper by the bowel. In the hepatocyte, we have the ATP7B protein in the cytoplasm that can link with the copper and can drive the copper in the vesicle to the bile duct. This is the function of the copper. Then, if we have an impaired excretion, we can have a manifestation of the toxicity of the copper, and for this we have a Wilson disease. If we have impaired absorption manifestation, the deficiency, we have the Menkes disease that is very, very different. In the liver, we know that the clinical manifestation of Wilson disease is very, very heterogeneous. The symptoms can appear at any age. Most cases are diagnosis between 5 and 35 years old of age. The clinical signs and symptoms may vary, but the most common are hepatic, neurological, and psychiatrics. For this, we have a classification of the form of progression of Wilson disease in non-neurological forms with preclinical that are the patient asymptomatics, or hepatic form, or we have a neurological forms with pseudo-Parkinsonism type, pseudo-sclerotic types, or mixed form, and psychiatric form of progression. As you know, the clinical manifestations are very heterogeneous, and these cause a really difficulty in diagnosis, especially when the first manifestation occurs in adult patients. We can have a start of disease with neurologic involvement without any other signs, or most common when patients arrive in our clinic with an hepatic unknown disease, he can present an advanced liver disease or an acute liver disease of unknown origin that need liver transplantation. For the hepatic manifestation, we can have asymptomatic hepatomegaly, isolated splenomegaly, fatty liver, acute hepatitis, or cirrhosis with all complications. For neurological forms, we have movement disorders, dysarthria, dystonia, migraine, insomnia. For the psychiatric form, we can have depression, neurotic behaviors, personality changes, and we know that other systems can be involved. For this, we have to search the Kaiser-Fleischer rings in the eyes, or we can have the cutaneous or renal abnormalities, pancreatitis, or menstrual irregularities. Early diagnosis of Wilson disease is essential for prevent further disease complication, but it is very difficult. And for this, there are be elaborated 3 guidelines that are different for the approach because we have different settings for presentation of the disease. We can have an asymptomatic or an early manifestation for disease, and for this we are in the settings of diagnostic testing, or we can have an acute liver failure due to Wilson disease or the family screening setting. The routine tests that are present in all guidelines are the serum ceruloplasmin, 24-hour urinary copper, serum-free copper, and the eye involvement with the Kaiser-Fleischer rings. But all these tools can have false negative and false positive results. The basis of this test has been elaborated score, the Leipzig score and Leipzig score modified, that link clinical signs and symptoms with other tests, such as the liver biopsy, urinary copper, and mutation analysis. On the basis of this test has been elaborated score, the Leipzig score and Leipzig score modified, that link clinical signs and symptoms with other tests, such as the liver biopsy, urinary copper, and mutation analysis. Score help us to identify the probability to have a diagnosis of Wilson disease. The American guidelines show a different approach based on a step-up evaluation. In the American guidelines, we have the same tool for the diagnosis, but we have now a score for the prediction of the disease, and in unexplained liver disease, or in a setting on a psychiatric disorder with different signs of the disease, they use the liver biopsy and the genetic testing to confirm the presence of the disease. In both American and European guideline is to show the important to detect rapidly the Wilson disease. Wilson disease should be considered in any individuals between 55 years with liver abnormality. It must be excluded in any patient with unexplained liver disease, and we have to search high involvement with Kaiser-Fleischer and a neurologic involvement through the magnetic resonance. The milestone in Wilson disease management is a rapid diagnosis, and because the patient have to start immediately the treatment. The treatment has a dual purpose: copper excretion from the body, a reduction of the absorption and control of the diet. In addition, the therapy must be pursued for lifelong. The first treatment is the control of the diet, because we know that the copper is more present in any element, such as vegetables, grain, legumes, meat, chocolate, shellfish, and nuts. For this, dietary recommendations have been developed. Patients with Wilson disease should avoid copper-rich meals and should consume low-copper water. These recommendations are of particular importance in the first years of treatment. Current evidence indicates that the unstable patients who are adherent to medical therapy, this recommendation is unnecessary, but we have two exceptions that are the shellfish and liver that have to be avoided long life. Indeed, alcohol abstinence and hepatotoxic drugs remain permanent recommendation for life. The drugs that are approved for treatment of Wilson disease are divided in two types of approach of use. We have the dipenicillamine and the trientine, and both are agents mobilizing copper from tissue and increasing its urinary excretion. And then we have zinc salts that are agents preventing copper absorption. The dipenicillamine is the indication of the dipenicillamine is the first line treatment in the induction in adult patient with hepatic manifestation. Trientine is the second line treatment for the induction in the first period of the disease. Zinc salt can be used as a maintenance treatment or as a first line in the setting of patients such as children or asymptomatic patients or neurologic patients. But we have a number of studies focused on new approach for treatment of disease. We have new agents and new treatment strategies. We want once daily dosing of trientine for better patient compliance. New studies are on biscolin tetrathiomobilidate with the advantage of neurologic improvement. We have other studies on gene therapy and cell therapy. That means transplantation of normal hepatocytes. This is very important because we know that in acute liver failure or in chronic liver disease with end-stage liver disease, the only therapy is the liver transplantation at this moment. In conclusion, it is very, very important the diagnostic suspicion in rare disease, because we can have a clinical aspect of the other more common disease, but in Wilson disease we can have an hemolytic anemia with the Coombs negative, or we can have an aspect of the liver with steatosis. And it's very important because the guideline for the evaluation for the rare disease are at this moment at step 3. Well, the challenges in Wilson disease are more. The clinical presentation is heterogeneous. Wilson disease should be considered and ruled out in any patient who is older than 3 years and presenting with unexplained liver disease of any liver of severity. Genetic fails, we know that genetic fails to predict the phenotypic variability in Wilson disease. It is likely that interacting epigenetic and metabolic factors are contributing to the varying phenotypes of the disease. The determination of free copper is very, very important to understand the disease, the treatment, the compliance, but is very difficult, and we don't have only one method to detect it. Both European and American guidelines rely on liver biopsy and genetic testing to complete the diagnosis assessment today, and for the future we need new therapies for all patients. Thank you.
Wonderful. Thank you, Dr. Tortora. Again, fighting Wi-Fi connection issues. I now know how we feel when we do Eurovision, so I can only apologise for the technology and admit that once again the UK comes back with nil points. But we will get there. We are definitely fighting the technology again, but we will definitely get there. So at this juncture, I would like to invite Dr. Reiberger to try once again. So we'll invite Dr. Reiberger to come on screen, and we'll ask him once again. Hello, sir. Nice to see you. We will try again. So he's going to go live with his presentation. And we are going to discuss adult rare liver disease and the challenges that are there. So we're just waiting for Dr. Reiberger to unmute his microphone, and then what we'll do is we will start live. Good afternoon, sir.
I would need to restart because the system preferences would not allow to share my screen yet. So I'm sorry, but I would need to go out and in again. I'll try.
Okay, perfect. In that case, we will come back to you again very shortly. So what we will do then is we will go to our next presentation, and we are now going to go from one of our clinical experts to one of our patient experts. So we will stay in the Germanic states, and we are going to go to Ingo van Thiel, who is part of Deutsche Leberhilfe over in Germany. So we're going to ask Ingo to come and join us, and Ingo is going to present about liver patients and how the pandemic has actually impacted upon the work of liver patient organizations, and obviously the lives of liver patients as we go. So we will fight the technology, and we will invite Ingo to come back to us, and he will present on how did the pandemic impact upon our work and our liver patients. Now, do bear in mind that we have other things that we would like to share with you. So while we're waiting on Ingo to come in live, I'd love to go back and talk about this toolkit. So we would love for you to share on social media why you're rare aware, or in what way you're rare aware. And again, if we can encourage our colleagues, our compatriots to to also join the campaign. I think it's a real opportunity for us as we move towards Rare Liver Aware Day on Rare Disease Day on the 28th. Then that would be absolutely fantastic. So we will pop the banner up just now while we are waiting for Ingo. So over to Ingo now. Thank you very much. Thank you.
Hello, my name is Ingo van Thiel, and I work as patient advisor and editor at German Liver Aid, Deutsche Leberhilfe. Our subject today is how the pandemic impacted our work, our information work, and of course, our liver patients. It's a German view, but I hope it's also helpful for you. As you can see, this is what we used to do in 2019. Fortunately, very little of that was impacted in a negative way. If you look at 2020, everything continued, although from home office. The one big thing that changed was that our local seminars, like patient seminars and training seminars for patient advisors, are all taking part online. And this both has advantages, but also some disadvantages. Positive is that we can reach anyone everywhere and they don't need to travel. And that, of course, saves a lot of time and money. And we saw with our very first online seminar 2 years ago that we had more visitors than ever. 400, we never had that at a local seminar. Negative is, in some aspects, it's less personal. And of course, those people who still do not use the internet are excluded. And this is why, once the pandemic allows for it, we will also reintroduce the local seminars, but we will definitely also stay with the online. We got a taste for them during the pandemic, and they work really well. When you look at the subject we used to cover, it already was a list. We also have some rare diseases among our main subjects like autoimmune hepatitis and PBC, and quite a few other diseases. And also here, I'm glad to say that the pandemic did not stop any of that. It just became a big subject. And it's such a big circle because it basically affects all the other diseases too, because patients with those diseases also wonder, what does this mean for me? The other thing is that we were also able to expand the list of liver diseases that we have information on our website. And we plan to continue that and expand it even more in this year and the next few years. Now to the most important part of all, what did the pandemic mean for our patients? And of course, as we know now, the sicker you are, the higher the risk if you catch the infection, especially if you're unvaccinated. And we've seen now that people with cirrhosis, especially decompensated cirrhosis or liver cancer, are at very high risk of serious COVID. We've also seen that fatty liver disease, NAFLD, may be a risk factor, maybe an independent risk factor, but we have to take into account that people with fatty liver often also have other diseases such as being overweight and having diabetes and high blood pressure. And all these are also risk factors that may also play a role there. The good news for us was seeing that the underlying diagnosis does not make much of an impact. So if you have early PBC, early autoimmune hepatitis, PSC, viral hepatitis, it does not seem to make a big difference for your personal risk compared with the general population, which doesn't mean COVID is harmless, but still it seems like the basic diagnosis is not making such a big difference. Another thing that you see in small print here is, and we learned that very fast, is it doesn't help to reduce immunosuppression unless your doctor tells you so. And then it's a very special case and they have very good reasons. But it's in general not a good idea. Patients should not do it without doctor's advice. It's not going to help against COVID, and it's not going to help very much with the vaccine either. So please, if you do take drugs that suppress your immune system, do it as your doctors advise you to. What we've seen and what many countries have seen, as far as I've heard, is that liver services were also impacted. Clinics were burdened with COVID patients. There are long waiting times. Also, especially when there were no vaccines, many patients canceled their appointments because, understandably, they were afraid of catching COVID in the clinic. They are less afraid now, usually thanks to the vaccines, but it's still an issue. And we don't know how much this has already impacted the long-term prognosis, but we know that the delayed diagnosis, delayed screening, delayed treatments already have had a negative impact also for liver patients. We have heard of cases where liver cancer was discovered too late or treated too late. And while we don't know the whole dimension, we are still to see how much this has damaged hepatology and its patients because other treatments have been delayed. Finally, on this slide, we do recommend the COVID vaccine very heartily, and we're not alone in that. Hepatologist networks such as the European Reference Network for Rare Liver Diseases, EASL and AASLD, also make a strong recommendation for the vaccine in liver patients. Now, the subject of COVID, of course, is also something that's on the mind of our patients. And the most frequently asked question changed. Of course, when the disease first came, the question was, how dangerous is COVID-19 for my liver disease? Could my PBC or my autoimmune hepatitis get worse from it? And this seems to have changed when the vaccines were available. Many patients, not all, many are happy to have the vaccine, but some who are worried seem to be more worried about the vaccine than the disease now. And now the most popular question we get, how safe is the vaccine for my liver? And should I take it and can I take it? And our answer as liver health is, of course, yes, you should. And there is a reason for that. The first one is that it's much more unlikely that you get severe COVID if you are vaccinated. Also, we now have a lot of safety data globally. There have been more than 10 billion vaccine doses worldwide, and we have had almost 2/3 of the whole world population who have at least received one dose of the vaccine. And this is also being monitored. So we have a very, very vast and good picture now what the vaccines do and how safe they are. And it shows they are just as safe as other vaccines that have been around for years and decades. What's very rare and possible is that people have severe allergic or autoimmune reactions. And what's especially interesting for patients and a cause for worry is that there have been single case reports, again, single reports among billions of vaccinations, that patients developed autoimmune hepatitis-like inflammations of the liver in the first 2 weeks after the vaccine. But that's really rare. And when we speak with our hepatologists, they still don't agree if it's really caused by the vaccine, if it's still a coincidence. I think we will learn a lot more about this in the coming months. But even if it's caused, it's really rare, and it's likely not any more frequent if you already have an autoimmune liver disease. So if you have autoimmune hepatitis, if you have PBC, you should not worry about this. Do get vaccinated. It's just as recommended as other vaccines like for hepatitis A and B or influenza, and it's just as safe. What we frequently see, and that's typical for vaccines, are reactions at the injection site. So you notice that you've had this prick. It may be a bit painful. Some people may have inflammation, which usually goes away within a day. A lot of people also report that they have headaches, they feel tired or have flu-like symptoms like fever. And what's interesting is there was a new analysis of all the phase 3 approval trials that showed actually a nocebo effect. Now, if you haven't heard the word nocebo before, it's the opposite of placebo. You expect it will hurt you, and it's hurting because you expect it to do so. And you see that people who basically did not get the vaccine, but just a placebo as a syringe, they also reported headaches, being tired, and flu-like symptoms in 1/3 of cases. So this may also have an impact and also demonstrates the safety of the vaccines. This is the final slide of this presentation, and this is my outlook and my impression what the information work on COVID actually also means for us. It's challenging in many aspects, but also very rewarding. Challenge is many liver specialists are also now very busy with COVID-19 patients. The advantage of that is they also become experts for COVID-19 and can also advise us on this disease as well. One challenge for us is to keep track because the science and the virus evolve really, really fast at warp speed. So it's really difficult to keep track, but it can be done. And this also shows how important our information work is for patients to keep them informed about what's new, what the latest things to consider are, and to do that in simple, easy to understand language. One other challenge that we have is, for instance, with our quarterly Liver Patients magazine that comes out 4 times in a year, everything we print on COVID may already be outdated by the time it arrives in the letterbox of patients. And we now use a disclaimer in our print media saying, okay, this is true as of 2nd of March, 4th of April. And we always refer to our website where we can update things instantly as soon as we learn something new. One big challenge, and I don't have a good solution for that, is there's a lot of misinformation around. Emotion often weighs heavier than fact. There's a lot of mistrust in science and data in a subset of patients. Again, most patients are happy the vaccines exist, but some are still afraid or very strongly against it. And when you have someone who still doubts the vaccine after so much data had been around, it's really hard to counter that even if you give them correct information. I've never ever met someone who was against the vaccine who was not at least misinformed about one or two things, such as, oh, the vaccine might infect me or whatever. But even then, if someone's really skeptical, giving information that's correct is not always going to sway their opinion. Personal stories of someone that you know, if you know someone was very sick and they weren't vaccinated, or someone tolerated the vaccine very well like I did, I've been vaccinated and boosted, someone sometimes more impactful than data. And finally, there may be a bias depending on the angle at which you look at things. For instance, we as patient groups, when we ask around among patients with surveys how their experience with COVID was, we will probably get fewer patients with severe COVIDs because severe COVID patients will be in the clinic and they would not be able to respond to surveys. Also, we see the statistics that in the general population, alcohol use has greatly gone up. There's more complications in the clinic. It's also something that the liver associations, the professional doctor associations observe. But it's something that we don't get to see in our helpline and in our emails, maybe because it's a taboo subject that patients are not talking about, maybe because liver patients are still more cautious. This is something where it's a bit of a black box for us as patient groups, and where doctors may get to see more of that aspect of the medal in those patients who also drink more because of depression and the pandemic impact. On the other hand, as patient groups, we sometimes get a better picture of frequent misunderstandings between patients and doctors. The doctor explains something and thinks the patient has understood it, and the patient calls us and asks, what did the doctor mean by that? And when we get more of these calls, we sometimes recognize a pattern, which helps us alert the doctors. If you say it like that, patients may misinterpret it as meaning this, not that. So that being said, it's more important than ever for patient groups and doctor organizations to work together, throw together the information, because that really helps us to get a full picture of what the pandemic means for patients, and it helps us help the patients. That was it from me. Thank you very much for listening.
Wonderful. Thank you, Ingo. That was most helpful. And you raise a really interesting point when we talk about the instant changes, the fact that, COVID can change so quickly and the information can be out of date really, really quickly. So I'd love to maybe open up that in the discussion if we may. So fingers crossed, we are now going to go back to Dr. Reinberger, and we will see if we can have his presentation. This is going to be the most hyped presentation since the Bond film, No Time to Die. So, because we've been almost there and then not quite, and then almost there and not quite. So I can see Thomas on the screen. So we'll just wait for the slides to come and unmuted as well. Wonderful. Right. We will go for take 3. Dr. Reinberger, it's over to you. Thank you so much.
Thank you. I've uploaded the slides, and now you should be able to see. Okay, I was able to see them. Very good. I have already been impressed by the previous talks as well, and actually you will see that some of the aspects that we have heard will also reoccur in some of my slides as well. So thanks for inviting me. I'm very happy to take part in this Global Liver Institute online session. And as I was asked to talk about challenges in rare liver disease, I'm taking over the part of rare liver diseases challenges in adults. I'm from the Vienna Hospital, and we have heard about several rare liver diseases. I want to touch upon some of these rare liver diseases where we have particular expertise. You have been hearing this in the recording previously, so I'm not repeating this, but you can read this for your particular interest. And I'm starting with the first message that I want to transport here, which is some more recent European epidemiological data. So liver disease in general is a quite global health problem, and cirrhosis causes about 170,000 deaths per year in the European Union. Another 47,000 deaths are caused by liver cancer, and in the European Union we perform 5,500 liver transplants a year. So these are quite some figures here. And obviously, the more common diseases is alcohol-related liver disease, still viral hepatitis B and C. And with the upcoming pandemic of obesity, we have a rising prevalence of metabolic liver disease. And especially in patients with diabetes, the prevalence of hepatic steatosis of fatty liver diseases might be up to 70%. But still, there is a lot of undiagnosed rare liver diseases, and they might be even co-present in the patients that might have obvious alcohol-related liver disease, and that is important to know. And when we talk about, for example, autoimmune hepatitis, some of the rare liver diseases that are focused today, we see that the prevalence in Norway and in Sweden that were reported are between 10 and 16 per 100,000 inhabitants. So still quite some numbers here, and we need to focus on improving the care of these patients. And when we compare the incidence and the prevalence rates to Asia and to America, we see that the incidence in Europe is actually higher than in Asia and America, and the prevalence is also higher than in Asia and very similar to America. So there is also a global difference in these prevalence rates of autoimmune hepatitis. So particular challenge in adult liver diseases, in adult rare liver diseases. We've heard about Wilson disease, a rare genetic disease that leads to kappa overload and most prominent, usually liver and neurological symptoms. So since the talk was excellent, I don't need to go into detail here, but an important challenge that I want to highlight is within those patients that present with liver disease, which is actually more common than presentation with neurological symptoms. So about 76% of patients present with liver symptoms. However, the symptoms might be just asymptomatic transaminases. So actually, the first hint is a hepatological manifestation, but it's just asymptomatic elevations of transaminases. This is already a challenge for the diagnosis in this disease. And even if you go and suspect Wilson disease, you might not be able to detect the ATP7B genetic mutations or variants in about 21%. And on top of that, even if you detect the mutation, these are highly heterogeneous, and you can see some of the examples that were outlined by this European study here. So importantly, this is a disease that is not often diagnosed, and the diagnosis, even if clinical suspicion is there, is very tough, and genetics is also helping, but still often complicated. So this is a clear challenge as an example for genetic diagnosis in rare liver diseases. The second challenge that I want to highlight is immunosuppression with patients with autoimmune hepatitis. And actually, the most important message here was already given in the last talk. When COVID-19 came up, a lot of patients were concerned about the immunosuppression. And so were also patients with autoimmune hepatitis. And so it's very important to transport this fact that if the patients continue the immunosuppression for their indication of autoimmune hepatitis, they were not at increased risk for severe COVID-19. And in turn, continued immunosuppression actually reduced the risk of liver injury. So that meaning those patients who had actually stopped the immunosuppression due to concerns about COVID-19 had a higher risk of liver injury, in turn, a rebound of the autoimmune hepatitis. So this is important, and this is actually data that we can only collect when we collaborate within the European Union and globally to actually advise our patients the best way possible. The next challenge that I want to highlight is in patients with Primabiliary Cholangitis, or PBC, which is an autoimmune disease characterized by progressive cholestasis, mostly biliary fibrosis in later stages that will lead to cholestatic cirrhosis, most often seen in elderly women. And this is actually a disease that often presents at the very late stage, although the diagnosis can be very easily made based on lab tests and autoimmune serology. So this is very clear and evident in other studies, but more recently, we actually found that in our cohort in Vienna of PBC patients, we had 27% of patients presenting already with a transchronic liver disease, so equaling cirrhosis, at the first presentation at the clinic. And overall, 17% of all these patients had already also shown signs of clinically significant portal hypertension, so even more advanced cirrhosis. And this is relevant because the presence of portal hypertension, regardless of the underlying treatment, will increase substantially the risk of decompensation. We heard already what decompensation means for the patients. So these are then subsequently also at increased risk for death. But in turn, we have also identified, again, a very promising non-invasive set that can be easily applied to our patients, which is a combination of stiffness measurements, so FibroScan, and platelet counts in a regular blood cell count. So if the liver stiffness is below 15 and the platelet count is normal, the survival in this cohort of patients was actually at 10 years, 100%. Some of these patients were lost to follow-up, but still very promising, very easy. This can be repeated on the bedside. And so it is a challenge that we have already shown some promising strategies to tackle this in our patients with PBC. So some strategies and visions that can be also used to tackle the challenges, not only the ones that I've showed you, but also a lot of others are actually within the European reference networks. And we've heard about the Rare Liver Disease European Reference Network. And this is actually a network that is based on providing advice to national care centers based on clinical guidelines, sharing of research, innovation, and knowledge, and sharing of evidence, like, for example, the data that we collected for autoimmune hepatitis. And this is all going to training and e-learning in terms of the internet. This is actually opportunities that can all provide advice to the national healthcare providers. And at the national levels, at the national centers, this will actually ultimately result in improved treatments for the patients with rare diseases, in our case with rare liver disease. So here I want to show you that the rare liver ERN is actually based on 3 clinical pillars with autoimmune liver disease, the first pillar, with metabolic and biliary atresia and related diseases, the second pillar, and with structural liver disease at the third pillar. So I've also collected the numbers of patients that we've seen per year in our Vienna Rare Liver Disease Center, and you would appreciate that some of these diseases are very, very rare. Like, for example, polycystic liver disease, biliary atresia, choledochal cyst, but others are actually more common. But still, these are rare liver diseases that require substantial expertise to go forward with knowledge and to improve care of our patients. And some of the best practice examples that we had experienced at our Vienna Rare Center, I want to share with you. So we actually collected data on patients with alpha-1 antitrypsin deficiency. So these were patients that were actually in care either for the pulmonary disease or have been diagnosed already, but liver disease have not been evaluated so far. Most of these 42 patients had actually ZZ genotype, so the more severe phenotype in terms of lung disease, and some others had also MZ, SZ, and MS genotypes. So these are other genotypes that are usually not as severe in terms of their pulmonological symptoms, but the liver phenotype was not so well known at this time. And in this small cohort of patients, we have already seen that there is an increased stiffness also in the patients with the heterogeneous ZZ phenotype, genotype, but also in the ZZ, this even goes up. And the same applies for hepatic steatosis. So for the liver fat content, this was also higher, but due to the lower patient numbers, this differences was not significant. So later on, we collaborated with the European Consortium on alpha-1 antitrypsin deficiency, which is now guided by the Aachen Group. And we have seen similar data in a collected European cohort of patients with alpha-1 antitrypsin deficiency. And ultimately, in the larger cohort of patients, again, you see that the alpha-1 antitrypsin serum levels go down. So this has been already known, but it's a nice confirmatory test here. But at the same time, not only liver disease is more severe in these patients, but liver stiffness as a measure of fibrosis went up significantly. So a good example how European collaboration will increase the knowledge and ultimately the diagnosis and surveillance of patients with rare liver disease, such as alpha-1 antitrypsin deficiency. And ultimately, I would personally call for evaluating the care and actually the consequences of our European efforts in terms of important quality metrics that need to be defined. And for that, I would actually suggest 3 concrete steps that we could apply. Similar to the clinical platform that we have used in the ERNs, there should very, very importantly also be a pathological platform where we can upload histology slides, which is a key diagnostic factor in liver disease, as we have heard several times today. So this is a platform where histology can be shared, pathology can have reference resources, and ultimately patient cases can be stored anonymized. And this will basically increase the diagnostic criteria and care for our patients. The quality aims that we could compare for our, or actually set for our clinical management of patients are very diverge, but I give you some of the examples that are clearly indicating a higher level of quality in the care of patients, such as a call of about 70% of autoimmune hepatitis patients achieving remissions with immunosuppression within 12 months. This is actually what is expected from the currently collected clinical data. We should also query our patients with cholestatic disease about pruritus. The data here, it's a very important health-related quality of life aspect, but the quality of data here is not very granular. So we need to improve that, and we need to actively query our patients about this very important symptoms that dedicates also their quality of life. And we would call that 90% of PBC-PSC patients are queried. And at the same time, for PBC, we know that it's a very effective treatment, which is orthodesoxycholic acid. And we should actually aim that about 90% of our patients receive this treatment as soon as being diagnosed, and also at the sufficient dose. So those would be the second point for calling for quality aims in clinical care. And ultimately, since we have also a rare oncological diseases such as the cholangiocellular carcinoma, I think here we should really not miss the opportunity for biobanking. These patients are usually diagnosed by cytology or biopsy, and this material should be shared and assessed in greater cohorts. It's a very rare cancer, and we need to assess the oncogenic drivers based on molecular classifications. And this would eventually very likely lead to development or to even trials and effective treatments in patients based on the molecular subclassification, as we have seen for other tumors that are more common. And finally, this was the last slide. I thank you again for having me here, and thank you for your attention, and I'm also happy to take questions later.
Wonderful. Thank you very much, Thomas. And that was absolutely worth the wait. So thank you. And I appreciate that we had to juggle technology and connections and everything else, but we finally got there. So thank you very much. Now, it's amazing to watch the comments, and I can see the patient advocates talking to each other and arranging meetings when we do come together at EASL, be that digitally or indeed physically. And that's absolutely fantastic. And it's one of the great things that we do here at GLI is partnership working. And one of the things I want to highlight is next week, we are also doing a US congressional briefing. So again, this is more involved policy work. And if you want to get involved in that, or if you want to witness that, then the link for that will be in the comments. But you will see the banner running across the screen as I speak. So we have one more speaker, and I'm absolutely delighted to welcome the speaker, who is a friend from Liver Patients International, amongst other things. And she is the director of the Dutch Liver Patients Association, NLV. I'll let Jose explain what NLV means in the language of Dutch. But I am absolutely delighted to welcome Jose Willemse. Thank you.
Robert, thank you for the introduction, and the Global Liver Institute, thank you so much for letting me having this talk about a very important unknown subject, the hidden burden in the whole family when you have a child with a liver disease. A newborn with a liver disease, from a pink cloud to a dark cloud. I don't know, or it is an expression everywhere, but in the Netherlands it is. When you have a newborn, you are sitting on the pink cloud, you burst from proud and happiness, and then suddenly you notice that your child is ill, and you change from a pink cloud to a dark cloud. The child with a liver disease leads to a lot of adjustments for the family. Uncertainty about the course of the disease, sudden worsening of the condition, rushing to the hospital, often far away because the local hospital doesn't have the expertise. And the family is often going to use this because that's, for the most families, the problem, I think. I will not speak about the phases the parents go through, but about the hidden impact and consequences of a lot of uncertainty, a lot to arrange, especially if all the children are involved, grandparents, relatives, and friends. This will lead to really changing family dynamics. The relationship between the parents is changing. Being confronted with a serious ill child often changes the relationship between the parents because all the focus is on the sick child. They often lose sight for each other, and a divorce can be often the result. And unfortunately, we experience that very, very often. Parents have their own process. They are not aware of grieving of the other one. So there's no attention for the other. And that leads, as I said before, very often to a high rate of divorces. But also the parents and the other children is changing because the parents are very often away with the sick child to the hospital, or they need all the attention for the child at home. And the other children got less attention. And the consequences are very often, or they cut themselves off, or they scream for attention. Parents feel guilty and don't know what to do with it. There's also an issue about the parents, the children, and the grandparents. Very often, a grandparent will take over the role of the babysitter for the other children. And instead of a grandparent who's spoiling the children, they become educators for the other children. And it's difficult for the parents to let that happen because even if they don't agree, they don't have energy to interfere. And the children don't understand the role of the grandparents anymore. In the Netherlands, a 5-year-old boy asked his grandmother, "Are you my stepmother now?" So that's really, that hurts when you hear a 5-year-old saying that because he was so confused about the role of his grandmother. But there's something else, and that's the situation with your relatives and friends. That's changing too, because you have less time for visits and birthday. But there's something that's really more horrible. In the beginning, everybody is in shock and full of compassion and wanted to help. I'm always there for you. And if I need to cook, well, give me a call and I will take care of the other children and do your shopping. And everybody wants to help for a couple of weeks. But we know that the disease of the children is not a matter of a couple of weeks. And what you see, and that's where I start with, is that there's less time for visits and birthday. And the result is very often that you are not even invited anymore. And the excuse is, yeah, but you never can come, so we don't invite you because that will be very disappointing for you. So they turn it around. And that is really awful, and it hurts the families a lot. And there are also financial consequences of having a child with a liver disease. Very often, both parents have a job. And because caring for a sick child takes so much time, it often happens that one of the parents stops working. Often the mother, but it brings some peace in the family. But often it's a financial drain. There's less income, with the result that there are fewer opportunities for the extras in life, the fun things. There's no money anymore. But even worse, I know also some situation where the income drops to a minimum and the parents have difficulties paying their basic costs. And that are the costs we know, but there are so many hidden costs. Hidden costs are not reimbursed. In most countries, the hospitalization, the treatment, that's insured care and paid by the government or insurance companies. That's not a problem. But there are so many additional costs you don't think of that are not reimbursed. Sometimes, like the fuel cost of your car, in some countries like mine, the Netherlands, you can arrange that with your tax, but that's always a year later. So first you have to pay that. But there are so many things you never think of when you are not in that situation. And I have some examples for you. That's the travel cost, as I said before, from home to the hospital, sometimes very, very far away. But also when you are in the hospital, a coffee break in the restaurant of the hospital, because you don't want to be 24 hours in the room of your child. So you want to escape and say, well, let's go have a cup of coffee when your child is asleep. Or you want to have a dinner outside the hospital, extra cost. Or the grandparents or family members or whoever is coming to visit your child, and afterwards say, well, let's have a coffee and just have a talk. Costs money a lot. Or you buy presents to comfort your sick child, just something to hug with, just because you feel so guilty. And also you feel guilty to the other children who had to stay at home. So you buy them some presents. And even it's small ones, just a few euros or dollars, it doesn't matter. But it's cost, it's money. Or your babysitter who say, no, I don't want that you pay my fuel or whatever. I do that because I love you. You buy some flowers or small presents. That's what you do. That's really what you do. Another issue is impact for the siblings. Their behavior change, depending on age, how and what, but it is changing. You can't ignore that because they have to cope with less attention of the parents. All the attention is for the ill sibling. And they understand that this person, the child who is sick, didn't choose for this to be sick, and with the accompanying hospital visits and treatments are not fun. They know that, but still, they can be jealous of the attention that the child gets, and they don't. And negative attention is attention too. And so it's really, it's not only what you see only for young siblings, also the other ones, they have the same behavior. And of course, it's so annoying when you wake up and your father and your mother is not in their bed, but you find their grandma or a good friend of the family because they had to leave in the middle of the night to the hospital with the sick child. That affects the siblings a lot. And what you see is that they have anxiety, but negative attention is still attention, as I said before, or they're being very quiet, or they have a lot of anger to people who take care of them while the parents are not available. They have problems at school, at their social clubs, their sports, mention it, and you see their behavior change because of the situation at home. And it's very important to be aware of that. So it's just what I said, what I mentioned is a little. And you understand that the list is so much longer that I can fill the whole conference with this, but I have only a limit of time. So the question is, can we solve this for them? Not really. These are situations that happen, and they are beyond of their and our control. And we know from experience that it helps a lot to acknowledge this and to talk about it and to let them talk about it with other parents in the same situation. That is very helpful. We saw that in the Netherlands when last year we organized a day for families with a young child with a liver disease and their siblings, a day in the zoo. And we separated children from the parents, and they stayed together with a guest speaker on family dynamics and well, the opportunity to talk with each other. And the children went on a treasure hunt through the zoo with volunteers, and we invited also a babysitter who they are familiar with, could be grandpa or a friend, or it doesn't matter. So they left for 2 hours. And what happened then with the families or with the parents, that was really, really so good to see that they were so happy to speak with each other. They didn't have to explain what's happening with them and their worries and their frustration and what. So we know that giving parents the opportunity to speak with each other and warn them that, listen, hey, things are, the dynamics between your family in your family are changing. That was really an eye-opener for them. So, and what I want as an executive from my patient organization, I want just a day to spoil them, and that went well, I can assure you that. And there was a mother who told me, well, this morning session that we could speak with each other, it could take the whole day. I could stay there for the whole day, but well, the afternoon with the family, because they could stay in the zoo until closing time, that was fun too. And there was a father who said, what you told us about, well, why you wanted to have this day, because you are aware that a lot of families don't have money for that anymore because one of the parents quit the job. That is so true in our family, and so we are so happy with this opportunity. And these are things that people are not aware of. So I knew that for sure that day was a success and that beautiful things are happening. So can we solve the problems? No, but being aware of it, that helps already a lot. So I want to say one more thing to you, and that is on behalf of all the families with a child who is suffering from a liver disease, thank you for your attention. And please think about this when you are aware that there's a family with a sick child. Doesn't matter what, but in our case, the liver disease. And think about the hidden burden they have. Thank you very much for listening.
Wonderful, Jose, again. And you make great points, in terms of reminding us that liver disease does not just affect the patient, the person with liver disease. So thank you very much to all our presenters. I'd love to open up the panel now, so we'll see everybody appearing on screen, and we'll invite some questions. We have about 12 minutes left, so we'll do a couple of questions and see what we can pull together. So we have yeah, absolutely. And Angela said, I'm moving it down to our presentation for music. So thank you. Absolutely. Okay, welcome back. We have some background noise, but we'll try and get through this. So I have a couple of questions, if I may. And we've spoken about children with liver disease. We've spoken about adults with liver disease. We've talked about the families and everyone around the patient. But what we've not really discussed is the most underserved of all the underserved of the underserved of the subgroup of the underserved, who are absolutely the most underserved, and those are the pediatric patients who are transitioning into adulthood. So do we have any thoughts on how we can maybe ease that transition and what needs to be done to improve that journey for the patient and their family? So Jose, if I may, I'll come to you first, and then Denise, may I come to you as well? So, but Jose first.
Well, that's really a big issue. And I've quite a clear view on that. What you see, not only with liver disease, but what you see in general is that at the end of the time of the pediatrician, the doctor from the adults come to the doctor, to the pediatrician, and just to know each other, look at hand, well, I'm doctor, and I will be the doctor next time. And that's the doctor for the adults. And then the next time they went to their doctor, completely different atmosphere when you go to the clinic for adults, and that's it. But in my view, transitions start at a very young age. It's not only about your new doctor. It is about taking care of your disease, learning what your disease is, and more important, the consequences of having that disease. How do you do that at school, or when you want to have an extra job just to earn some pocket money? Just how do you survive in a group? And those issues are so important. I know in the UK and also in the Netherlands are programs for that.
Yep.
And also to learn the children, but also to train the parents just to stay away more when the children are growing up. And we see, and I think for the pediatrician part, it's there we have wonderful problems, but I see really a big challenge, and I know that we have, well, I know I'm part of it, working with at ERN for that transition. We need more awareness for that with adult doctors, because the questions who are asked by the pediatrician are not asked by the adult doctors, but so important for the young adults.
Yeah.
And it's not always that they want to be back at the pediatrician, because sometimes they are so bored and it's so childish there, so they're happy to be in the adult world. But we see that they miss a lot of questions which are so important for them. So I think there's a big challenge to go there, and I'm
Yep.
sure that we will be there. The transition is really more than going from your latest visit from the pediatrician to the next visit to the doctor for
Yeah,
adults.
absolutely. So thank you, Yossi. Professor Denisi, do you have a view on what can be done to help transition for patients?
Thank you for the question. I think it's really an important and relevant issue, because transition, at least at the scientific level of the scientific society, maybe is a problem that is not completely solved, but there are some examples. The International Society for Metabolic Diseases, the SSIM, has created a focus group on adult patients with metabolic disease. So at scientific level, I believe that the problem is ongoing and is already under evaluation. While the real problem is at clinical level, and I believe that the EARNs probably will represent the best way to improve the system. So I think I'm talking from my point of view as a pediatrician living in Italy. In Italy, there are very few examples of transition for metabolic patients. In Europe, there are good examples in the Netherlands. There are good examples in UK. Some good example also in France, but in the rest of Europe, there are really handful cases that we can list as good example for the transition. And I believe that the internal medicine should understand the importance of creating some specialists in metabolic diseases, because as pediatrician, we are the internal medicine of the baby. And the real problem is when our patients move to the adult medicine, they are managed by organ specialists. We have heard about Wilson disease. Wilson is a metabolic disease that has at least two arms, the neurological disorder and the liver disorder. And who is the specialist for Wilson disease? Is a hepatologist or is a neurologist?
Yeah.
In metabolic diseases, generally is a pediatrician. It is the internal medicine who manage both problems. So I think we really need doctors, adult doctors, who have the capacity and the expertise in many organs and systems.
Perfect. Okay, thank you very much. We're going to move on to one last question now, and bearing in time we have 1 minute, and it's a nice small question when we consider we each have 1 minute to answer. The question, it goes back to Professor Buti, it goes back to Dr. Reiber, it goes back to Ingo, who spoke about the fact that the collaboration between clinician and experts is more important than ever. So my question is to each of you, what one step would you like to see made now or in the very near future to improve the life or the journey of the rare liver patient? So no pressure, but Thomas, I'm going to come to you first, if I may. What's the one step you would like to see?
So for me, it's really some extra resources for the centers who have already, shown a lot of dedication. We have seen that within the European reference networks, those centers who were now most active and that they provide very important aspects, I think they should now be honored a little bit by giving some extra resources. And I'm very sure that this will eventually come back. I think by now this is really the nadir in going further. it's clearly that without time and other electronic database resources, this will not be possible to go the next mile, because the personal dedication is already there.
I understand. Thank you. Okay, perfect. Ingo, if I may. Oh, you muted
I just
yourself.
muted myself again. I'm back. So I think on the scientific side, what we really need for all rare liver diseases are more registries. There are so many open questions, not only about the cause of disease and the clinical aspects, but also about what it means for daily life. And there have been great examples made, as in PBC, where there's now extensive data. And I would really like to see that extend to other rare diseases, such as biliary atresia, PFIC, etc.
Perfect.
And I think besides that, to add a second thing is we should really continue our cooperation and help each other, help our patient groups to extend our information on rare liver diseases just to increase our list. It's also a personal goal I've been taking for Deutsche Leberhilfe. We've been increasing the list of diseases this year, and I plan to do more, both for the rare diseases, but also for more frequent things that are still missing, like gallstones. We will tackle that as well. And it affects people with rare liver disease as well, such as the Caroli syndrome. So these are the two things I would really like to see extended.
Perfect. Thank you very much. Professor Denisi, if I can come to you next, please. What's the one thing you would love to see?
I think in the last lecture, we've heard about the objective of increasing awareness and increasing understanding. I think the last objective will be the empowerment. We've heard about the siblings. This is a major problem, and I think the empowerment is not only for the patients. The empowerment should be targeted to the families, to the entire families, and in particular to the siblings. So I think for the future, the real alliance that should be done together with the patient advocacy group is to have these three main vectors: empowerment, awareness, and understanding.
Wonderful. Thank you very much. And as if to take a cue from Professor Denisi, I am actually going to come to the patient voice last with empowerment in mind. So you'll say again, same question. What's the one step that you would like to see to help improve the patient
Sorry,
journey?
can you repeat that? Because we have a storm going on here.
Okay. So my question is, what's the one thing you would like to see, the one step that will most improve the journey or the quality of lives for rare liver patients?
I think that's just to know what the unmet needs are. And we are working on that because there are a lot of unmet needs. And I think knowing that makes it for everybody, also the clinicians, easier to understand why people respond, how they respond. And it's not only the clinical facts on your screen from the test results coming from the laboratory. But knowing that, and I think that will improve the treatment, the relationship between doctor and patient, and then actually the quality of life.
Perfect. Thank you, Jose. I'm very, very much appreciated. The experts in the room, so Professor Denisi, Dr. Eilberger, Ingo, Jose, thank you very much. Professor Booty, who started us off, and Dr. Dortero as well. Thank you so much for sharing with us. So those of you that are watching this, you know who the experts in the room, you know who the people are who are open to collaboration, you know the people who are interested in greater understanding, greater empowerment, and greater empathy and compassion with the patient journey. So please, please do come work with us. Let's make the next steps together. Everyone who's joined us today, our panel, our speakers, our audience at home, thank you so much. We bid you well. Take care. Bye now.
Bye-bye. Thank you. Bye.
you.